the about clinical use of ketamine and my experience of it, and then the second part of the talk will be a bit more focused on potential mechanisms that might be underlying ketamine and new questions around how it might work, and other alternative medications that might be a good alternative to ketamine. So we'll start off with disclosures. I've been a principal investigator or sub-investigator on studies that were sponsored by Takeda, Janssen and Lundbeck, and I'm also going to be discussing the off-label use of ketamine. So, ketamine is a drug that was developed in the 1970s as an anesthetic agent. It's still used for anesthetic purposes because it's got a very favorable profile in terms of its properties in terms of not reducing, not causing respiratory depression in people when it's used as an anesthetic. But when it's given at lower doses, sub-anesthetic doses, it can cause changes in people's perceptions, like distortions, and strange beliefs, delusion-like ideas. And also at the same doses, at these kind of sub-anesthetic doses, ketamine has also been shown to have antidepressant properties in people who have treatment-resistant depression, and also in people with bipolar depression, who I'm sure you know are a very difficult to treat group of patients. So the discovery that ketamine was an antidepressant was really a complete breakthrough in psychopharmacology. We found that it was found that people who were completely resistant to other treatments showed a good response to ketamine. And secondly, that these people who had a good response to ketamine, the response occurred within minutes or hours rather than weeks. So with conventional antidepressants, I'm sure you know, take 2, 3, 4 weeks before you can start to see an antidepressant effect. Whereas with ketamine, this effect occurs within an hour or so of giving the dose. The first randomized controlled trial of this was Zerati, published in 2006, and this showed an immediate effect of ketamine on treatment-resistant depression. And the antidepressant effect was maintained for approximately 7 days. So these are graphs from the original study from 2006. The black lines are placebo, and the open circles are ketamine. And you can see that ketamine caused a reduction in depression scores from the infusion, and these lasted up to. The second graph here is looking at brief psychiatric rating scale, so the psychosis-like effects of ketamine. These were present around 40 minutes after the infusion of ketamine, but they returned to normal by within 80 minutes. And lastly, looking at Young Mania Rating Scale, so manic-type symptoms, which were present in the ketamine cohort, again at 40 minutes, but these reduced to below the level of placebo by day 1. And on the right-hand side of this slide is the second, and this was looking at people with bipolar depression. So people with bipolar depression often don't respond well to conventional antidepressants, very hard to treat, whereas both groups, type 1 and type 2 bipolar, showed a good response to intravenous ketamine. And also, it was noted that in this study that it had a significant effect on suicidal thoughts in these people. So there was an instant reduction in suicidal thoughts at 40 minutes that lasted out to day 3 in these people with bipolar depression. This idea about ketamine being potentially anti-suicidal has gained a lot of interest. Been a number of studies looking at this. This is another study from 2009 where this was looked at directly and found that in patients with treatment-resistant depression, that 81% of these people who had suicidal thoughts scored 0 to 1, which is basically no suicidal thoughts at all, within 24 hours of the first infusion. So there's been a lot of studies of ketamine. This is from a meta-analysis from 2016, looking at the time course of antidepressant response in people with treatment-resistant depression who are treated with ketamine. And this is looking at response, which is classed as 50% reduction in the Montgomery-Asberg Depression Rating Scale, the MADRS. And in this meta-analysis, the studies have shown that there's a significant response to ketamine that's present at 40 to 60 minutes, and it lasts right up to day 7, which is down here. This second slide from the same meta-analysis is looking at people who went into complete remission following ketamine, and there's a significantly higher number of people in remission following ketamine, and right up to day 5. There's been some other studies looking at use of ketamine clinically, and this is a very nice study published last year looking at comparing the use of ketamine to ECT in people with treatment-resistant depression. And in this study, the ketamine was used. People were randomized to either having ketamine or to ECT, and was looking at, so these were people who were very severely ill with depression, and looking at the outcomes. It looks from this slide like the ECT was probably more effective once you get out to the 12th infusion, or the 12th dose of ECT. But this was not significantly different. So there was no significant difference between clinical response to ECT or to ketamine in this quite large study. And also in that study, they were looking at side effects, and the ketamine group actually had much lower side effects, particularly around things like cognition and memory loss than the ECT group. So there was a suggestion that ketamine could be used in people who would normally have ECT, maybe if people can't cope with having the anesthetic, or if they have problems with cognition and so on, that might be worsened by ECT. So these studies so far have all talked about intravenous ketamine, and this is probably the commonest way that ketamine is given these days, at present. So the trouble with using intravenous ketamine is its off-label use. So you're not, it's not allowed to be prescribed generally unless there's a specific reason to do this, and the doctor has to take responsibility for prescribing the ketamine that hasn't been approved by the governing bodies like the FDA or the MHRA. So that's a big problem with it. Also, intravenous ketamine causes dissociative side effects. So people can have odd experiences, delusions, perceptual distortions, whilst the ketamine is being infused. I should point out that these effects only last for a very short time. So once the ketamine infusion has stopped, all of those dissociative side effects will disappear very quickly. But that is a problem potentially, can be frightening for people or problematic. It's still unclear as to whether these dissociative symptoms are really essential for the effects of ketamine, the antidepressant effects of ketamine. So that's work that needs to still be done. Also, intravenous ketamine requires repeated dosing. So although people often respond well to a dose of ketamine, once it gets to a week later, the depressive symptoms will start to return, and they might need a repeated dose. Also, with intravenous ketamine, long-term safety is still unclear. We haven't had enough long-term studies with this. Potentially problems around bladder and cognitive function that occur in people who abuse ketamine and use it in very heavy doses as recreational users. Which could potentially, theoretically happen when ketamine is used as an antidepressant, although to date there is not any evidence that this happens. Lastly, I've said there's potential for patients to try to self-medicate or try to obtain illegal ketamine.
James, may I ask something?
Yeah.
You were saying about the repeated dosing. How many times that repetition is required for IV?
That's a very good question. So the number of repeated doses there's no agreed amount, basically. So I'm going to be talking a bit later on about centres in the UK and what they do. In terms of repeated dosing, many centres will just carry on giving a dose every week as long as the person carries on responding. So in Oxford, in the UK, people have been dosed for several years with repeated dosing in ketamine. There is some evidence, though, that maybe after someone's been treated for maybe 6 months or so, that there could be a potential to stop. But I'll talk a bit more about that later.
Yeah, thank you. And are you going to also talk about IV versus other route of administration?
Yeah,
okay.
Yeah. Okay, so yes, just onto other routes of administration. I'm just going to talk now about S-ketamine intranasal spray. So this, as you will know, has been developed by Janssen, and it is made just with the S enantiomer of ketamine, which is basically ketamine has, when ketamine is normally given, it's a racemic ketamine, and this is a mixture of R-ketamine and S-ketamine. Janssen chose to just use S-ketamine because it has a higher affinity for NMDA receptors and potentially has more. They thought it might have more antidepressant effects. As we'll see later on, this might not necessarily be the case. So this is the way that the S-ketamine nasal spray works. It's intended for administration by the patient themselves, and each device has a double spray, so it can be used twice. And each device contains 28 milligrams of S-ketamine. So the normal starting dose is 56 milligrams of S-ketamine, and for this you have to use 2 of these devices. If the clinician thinks the person hasn't responded well enough to this, they can go up to 3 devices on each occasion, and this would normally be done on a 2-weekly basis, so twice a week. After giving the device, there's a 5-minute rest, and then the patient needs to be observed under supervision until the patient's ready to leave. And there were some thoughts that S-ketamine might cause lower levels of dissociative side effects, but unfortunately this doesn't seem to be the case, certainly not in my experience. People can have quite strong dissociative symptoms with S-ketamine. So this slide just shows a bit of an outline of how they came to the right dose of the intranasal ketamine, S-ketamine. They looked at 0.2 milligrams per kilogram intravenous S-ketamine, and then they compared this to different doses of intranasal. And you can see that a single dose comes just here, which is quite a lot lower than the peak for 0.2 milligrams per kilogram. I should point out I think they chose 0.2 milligrams per kilogram because it is, we know that S-ketamine is about double the strength of the mixture R and S-ketamine, and so 0.2 milligrams per kilogram is probably around the same level as 0.5 milligrams per kilogram, which is what is normally used for racemic ketamine. Anyway, so 1 device is equivalent to, is a bit lower. 2 devices is just below the peak. 3 devices goes over this peak. So somewhere between these 2, you'd expect to be the kind of sweet spot for antidepressant response. So this is the way that S-ketamine is used. The person has to start an antidepressant. They start ketamine, S-ketamine, and this is given twice a week for 4 weeks. So this is one of the studies that Janssen did, looking at the maintenance of S-ketamine, trying to find out how many times, how long it needs to be given for. And so to start with, patients are given it 2 times a week. Then the frequency of administration of the S-ketamine reduces to once a week for 4 weeks. And then there's a continuation phase after this. So this is a total of 8 weeks for this period. After this 8 weeks, the S-ketamine can be continued, but it can be given every week or every 2 weeks as the clinician decides. And Janssen have said that after depressive symptoms improve, treatment is recommended to carry on for at least 6 months. This is the results of their trial looking at antidepressant effects of ketamine in patients with treatment-resistant depression. They found that this group is the placebo arm, so this is placebo plus a new antidepressant, whereas this is ketamine, the S-ketamine plus a new antidepressant. And there's a significant difference between these. 70% people responded, and 50% of people in this trial went into remission. This is compared to 30% just on the new antidepressant alone. Janssen also looked at, as I said, looked at the way that S-ketamine could be maintained, how long it could go on, how long it needs to be treated for. And so in this study, they had people on nasal S-ketamine and oral antidepressant, and they split these people into remitters and responders. And for both of these groups, they randomized them to either carrying on S-ketamine or switching to nasal placebo. And then this maintenance phase went on for a variable duration, and they were followed up for 2 weeks. And this is the results from this study, which is very interesting. So as you will remember, these are people who've been treated for 6 months. They've fully responded, and then they're either switched to placebo or they are maintained on S-ketamine. And you can see this is the group that stayed on S-ketamine. Many more of them remained well. But even in the group that switched to placebo, there's still around up to 40 weeks or so. There's not that much difference between these two groups. So there's a good evidence that a certain proportion of these people who have responded by six months will carry on being well for a significant period of time, even up to the end of the study, which was 80 weeks. And this is just looking at the same, but looking at people who are responders rather than fully remitters. And a similar pattern, although when you're looking around the year level, we're looking at about a 30% response at this period. 30% of people still staying well. So this suggests that if people are responders but haven't fully remitted, it might be better for them to just carry on with the intranasal S-ketamine. This slide gives you a list of all the side effects that people have reported with S-ketamine. Most of them are, as you might expect, dizziness, dissociation, nausea, headache, sleepiness, sweating, loss of sensation or changes in sensation, vertigo and vomiting. Now this slide is interesting. This is looking at a comparison of intranasal S-ketamine versus intravenous racemic mixture ketamine. And this study was published by one of the people who's done a lot of work on S-ketamine. He found that there seemed to be a stronger effect of antidepressant effects in the intranasal S-ketamine group compared to the racemic. I think this needs to be viewed with a bit of caution, though, because there's been this other study that was published 1 year later, which looked basically at the same thing and found actually the opposite effect. So they found that S-ketamine had less antidepressant effects compared to intravenous ketamine. So it's a bit unclear as to why these two groups found different results using the same data. I think the takeaway is that both intranasal ketamine and intravenous ketamine are both both work as antidepressants, and it's probably a bit difficult to distinguish between the two of them in terms of their overall efficacy. So those are the two main routes of administration of ketamine, and I'm now going to talk a bit about other routes of administration that have been used. I should point out that the intranasal S-ketamine is the only route of administration that has approval, and so if you're wanting to use medicine without going off-label, then Spravato is the only way to go. But other routes of administration, as I said, have been tried. So this is, I've just looked at some different studies that have been reported. This is oral ketamine. This is called the OCTOS study, which was published quite recently in 2021. And they were looking at the effects of oral ketamine titrated up to a maximum of 3 milligrams per kilogram against suicidality. So they found a very nice effect of oral ketamine on reducing suicidal thoughts. And they also found that it had a nice effect on increasing people's level of overall functioning and reducing their depressive symptoms. So this is quite promising. There's obviously not so much data on oral ketamine, but it would be a much more easy mechanism of use, of administration. This is another study from Arabzada in 2018, again using oral ketamine. This was a randomized controlled trial, so this is a bit more believable, I guess. But they still found an effect of oral ketamine over placebo right out to 6 weeks. But you can see here there's such a strong placebo effect. You have to be very careful with studies of ketamine, especially open-label studies. And this is one more oral ketamine study, which was published by Dome and colleagues in 2018, which was just a single dose, which was 1 milligram per kilogram of ketamine given 3 times a week. And again, it showed a good separation from placebo that was present at 40 minutes and went right out to 21 days. Again, quite a strong placebo response, but the oral ketamine was stronger. So other routes of administration, sublingual ketamine has been very interesting because it's theoretically a good route of administration. It is absorbed quickly, more quickly than oral, avoids first-pass metabolism. And this is a study using sublingual ketamine, but at very high doses, 5 milligrams per kilogram in the US. So this is a private clinic in the US, and they've treated 1,247 patients using sublingual ketamine. And they published this paper that looked at the dividing the patients into responders who had showed an initial immediate response, people who showed a delayed response, and people who didn't show a response at all. I suggest that there might be that sublingual ketamine could be useful. As I said before, there's no placebo group, so it's a bit difficult to say anything more about this, but worthy of more research. Another route of administration for ketamine is subcutaneous. So this is a study from 2022. Again, this is a case series, so no placebo, suggesting that subcutaneous ketamine might have a very nice effect. And another study looking at intramuscular ketamine. Well, this suggests that this was a comparison of intravenous, intramuscular, and subcutaneous ketamine. And in this study, by Liu and colleagues in 2016, they compared different doses of ketamine given by different routes of administration. And in this, they did have a placebo group. What's really most interesting about this study is the intravenous group did worse. The placebo response is here, and even at the highest dose of IV ketamine, so the placebo response is this blue one, just in case you can't see. The highest dose ketamine, which is the normal treatment dose, is this grey line. So IV ketamine in this study, anyway, suggested didn't show a good response, whereas some of the doses of intramuscular ketamine, some of the higher doses of intramuscular ketamine showed a good response, although it was the kind of medium level ones that showed the best response. And then subcutaneous ketamine as well showed a very good response compared to placebo. So the next bit of this talk, I'm going to talk about a survey that I've recently completed with one of my research students, looking at the use of ketamine clinically in the UK and how it's used. So this is a slide showing where ketamine is often given. This is the Oxford Clinic. This is an ECT recovery bay, and for a long time they were treating people with ketamine alongside people recovering from ECT. So they'd have one of these bays free just for someone having an intravenous infusion of ketamine. As you can see, if you've only got one bed for people with ketamine and they take an hour to treat, that's quite difficult in terms of scalability. It's difficult to, you can treat maybe 6 or 7 patients in a day if you've got the clinic open for the whole day. But if those people need repeated dose, the clinic will soon become full. And so I think intranasal ketamine might have a potential for better scalability. You could use intranasal ketamine in a more of a kind of group setting, having people lying in chairs rather than having to use a bay and having to use IV infusions. So I've been very interested in the clinical use of ketamine, and in 2019 I set up the ketamine clinic at the Maudsley Hospital in London. I've actually been interested in setting this up since 2013, so it took a very long time to get to fruition. But in 2019 there was a change to how the ECT service was being delivered, and they developed this new service called Maudsley Advanced Treatment Service. And as part of this, we set up ketamine as an option. We started off. This is the first time we ever dosed with ketamine, and for this we were giving it as a sublingual dose, primarily because we didn't have access to an intravenous pump at the time. And this service went on. Obviously, it was just prior to pandemic times, but we carried on as a treatment service all through the pandemic, wearing PPE where necessary, and had good feedback from patients in terms of their response. And since my move to Sussex, I've also set up another ketamine clinic as well there, which I'm not going to talk so much about. This slide here just shows you about ketamine clinics in the USA. So this was a study that was published in 2018, and it goes up to 2016. And you can see in the USA, there was a huge number of clinics. They started around 2007, so very early. These are private clinics, maybe one per year between 2007 and 2010. Then around 2011, 2012, there was a bit of a spike. And you can see now there's around, well, in 2016 there were just under 50 clinics providing ketamine in the USA. So we wanted to have a look and see in the UK what the number of clinics were. The way we identified this is in Oxford, Rupert McShane runs a ketamine service and a peer support group for people who are using ketamine clinically. And there are 14 centres who are connected with the Oxford Clinic, and we emailed them all, asked them to take part in a survey. Got responses from 7 of them, so 50% response, which was not brilliant, but not too bad. We didn't provide any kind of financial reward for replying. But this shows you when the clinics were set up. The blue line is the first plan to set up the clinic, and the orange line is the first patient dosed. So this is the Oxford clinic here that started in 2011, and that one was set up as part of a trial. So the idea to set up the clinic and the actual setup of the clinic happened at the same time. However, after that, there's a bit of a lag time. You can see there's around a year or so between the initial plan to set up the clinic and the clinic actually being set up. And so at the moment, we contacted, out of the 7 clinics, only 6 of them had started to dose patients. Going through the routes of administration, intravenous ketamine was the most common. 6 centers were using that. 4 centers were using intranasal ketamine. 2 centers were using oral, 2 using subcutaneous, 3 using intramuscular, and 1 using sublingual. In terms of indications, everyone was using ketamine for treatment-resistant depression, but some other centers were also considering people with bipolar depression, PTSD, or anorexia as potential indications. In terms of the numbers of patients treated with off-label ketamine, 2 centers had not dosed anyone with off-label ketamine. 2 had only given off-label ketamine to 1 to 10 people, and then 1 had given to either 11 to 50 patients, 100 to 250, and the last one, which was the Oxford clinic, had given ketamine to around 400 patients so far. Looking at the MHRA-approved ketamine, Spravato, 4 centers had given that, whereas 3 centers had not used that. Sorry, got that the wrong way around. Four centers had not used Spravato, whereas 3 centers had. But each of these centers had only given between 1 and 10 patients Spravato. So it's a vastly lower use of Spravato than the off-label ketamine. So we found some other things in this study. Many centers excluded people with mania, psychosis, and 1 center with EUPD. 3 sites said that patients needed to stop benzodiazepines. 1 site also specified that patients needed to stop lamotrigine and pregabalin. Average age of patients was in their 30s, and more centers reported treating more females. Most centers here reported between a 50 to 70% response rate, which I suspect is quite high. A variety of different rating scales were used, with MADRS used by 3 sites, QIDS by 3, BDI by 3, and Hamilton Depression Rating Scale by 1. They also had different criteria, so most centers needed at least 3 treatment failures before they would consider people for ketamine. There are a variety of maintenance approaches, some centers using oral ketamine to maintain response. Only 1 site had a maximum number. This is actually the site in Eastbourne where I've been running my 2nd ketamine clinic, and we have a maximum number of treatments of 9. That's to limit so that we can have the maximum number of patients to provide information for the study. 3 sites reported no adverse reactions. 1 clinic in which 125 patients had been treated reported 1 suicide. 1 site reported atypical pain, and the last site, in which 400 patients were treated, reported tinnitus in 12 patients, 10 patients with an adverse response to the infusion, 5 with worsening depressive symptoms, and 1 suicide. So, in conclusion from this, 7 centers, I've identified 7 centers using ketamine to treat patients with depression, both under the NHS and in the private sector. Treatment regimens and inclusion criteria differed between different sites. Most sites are using off-label intravenous ketamine rather than intranasal Spravato, which might be due to the extra cost associated with Spravato. Most sites reported a good clinical response to ketamine, with a response of up to 60% remission, although this is likely to be a significant overestimation because of the unblinded nature of these services. And we need work at the moment to standardize treatments in these different centers. Okay, so that finishes this part of the talk about the clinical use of ketamine. I don't know if we want to break here and have questions for that part, or just carry straight on. We'll see what the moderators say. Shall I just carry on? Yes. Psychotherapy, okay, yes.
In the US, what we see is now all these IV clinics are popping up and people are going and hooked with the IV ketamine. How would you combine it with psychotherapy? Yeah,
so that's a really good question. I think psychological treatments obviously have been a key part of with the psychedelic antidepressants, the development of psychedelics as antidepressants, whereas with ketamine we haven't really used psychological treatments at all as a standard approach. I think the reason for this is just because of the places that these treatments have come from. So ketamine has often emerged out of anesthetic practice, whereas psychedelic treatments have a strong kind of hippie culture, counterculture background. But I think it's a really good question, and I think my feeling is that we're missing something by not combining ketamine with psychological treatments. There's been a really nice study just recently published looking at combining just ketamine with a very simple app in which the person had associated their self with kind of positive thoughts and good feelings, and that led to a maintenance and a prolongation of the antidepressant effects of ketamine. So I think that there's a lot of work to be done there, and I really think that it's something that we're probably missing out on by not doing. Yeah. Okay, so for the second part of the talk, I just want to look about the potential mechanisms of ketamine. So ketamine is an NMDA receptor antagonist. So NMDA receptors are very interesting neurotransmitter receptors. They sit in the cell membrane. They have a channel that allows calcium ions in. They have a magnesium ion that sits normally in the channel and blocks the current from calcium. They will only open if the cell is depolarized, and also if glycine and glutamate are both binding at the same time. So they're coincidence detectors, they're kind of logic gates. They could be helpful they're really key to memory, long-term potentiation. You can block their effects entirely by giving a drug that binds to this intrachannel site and blocks the site. So this PCP is one of the drugs that blocks this, and ketamine is another. So it's what's called an uncompetitive NMDA receptor antagonist. It binds to this intrachannel site of activated NMDA receptors, and it blocks the passage of calcium regardless of whether the cell is depolarized and whether there's any glutamate or glycine binding. So, and glutamate is important. It's the principal excitatory neurotransmitter in the brain. It's involved in learning, memory, and metabolism, and it's rapidly turned over. So around 60 to 80% of the total brain activity in the brain occurs by glutamate neurons, and there's rapid release and recycling from metabolic glutamate to glutamine in the brain, and that's around 80 to 100% of glutamate in the brain. So there's different types of glutamate receptors, ionotropic and metabotropic. NMDA receptors are ionotropic, and these are the ones that we're most interested in this talk. Glutamate neurons are generally projection neurons, i.e. they project from one part of the brain to the other. And the synapses are generally on dendritic spines. So this is a neuron with and you can see that, I don't know if this is still working. You can see there's dendritic spines on this part of the neuron. This is a fluorescence microscopy showing these dendritic spines in larger scale. And lots of things happen at these dendritic spines. This is a pathway that is the suggested pathway that ketamine might have its effects. So ketamine binds to presynaptic NMDA receptors that leads to an increase in glutamate release, which can activate AMPA receptors. And there's downstream effects on all these different molecules. One of the most important ones is this orange one in the middle called mTOR, and ketamine activates that, increases its activity, and it's thought that this kind of leads to downstream effects and neuroplasticity and increasing levels of synapses in the brain. Ketamine also, ketamine leads to increases in brain glutamate, as I said. This is a study from beta-mogadam from 1997, microdialysis study where ketamine was given to rodents, and it was shown that glutamate levels increased in the brain. The mechanism for this is shown in this diagram here. So the GABA interneuron here provides blocking inhibitory tone onto the glutamate neuron here. Ketamine preferentially blocks these NMDA receptors, loses this inhibitory tone, and this leads to increases in glutamate release. So this increase in glutamate from ketamine may be important in the antidepressant effects of ketamine. On the right-hand side of this figure, there is a nice study in rodents from 2011, where following ketamine administration, these rodents had a significant reduction of immobility time on the forced swim test. So this is a model for depression, for antidepressant effects. So ketamine caused reductions in this immobility time, suggesting it's a good antidepressant. But this could be blocked by giving a drug that blocks the AMPA receptor, NBQX. And so at higher doses of NBQX, the effects of ketamine were diminished. There's, in terms of the mTOR as being important with ketamine's effects, so this is the orange thing here. You can block mTOR using the antibiotic rapamycin, and basically that was done in this study. So rodents were given ketamine, they showed an antidepressant effect on the forced swim test, and then rapamycin blocked this effect, and suggests that mTOR is important for antidepressant effects of ketamine. Ketamine also shows increases in levels of dendritic spines in rodents, so when they're given ketamine, they show increased levels of synapse formation. So in depression, we know that there are various potential targets that ketamine could target. One of them is the subgenual anterior cingulate cortex, which is important in depression. It can be targeted by deep brain stimulation to improve depressive symptoms. It's also been shown to be reduced in size in depression and also in people with bipolar affective disorder. Another target for ketamine is low levels of glutamate in the brain. So this slide shows a fairly old meta-analysis of brain glutamate. That this has been shown again in a more recent one. Also, there may be changes in connectivity in the brain, and ketamine might disrupt those and help with the antidepressant effects. So these are potential mechanisms that ketamine might have. It could modulate cerebral blood flow. It could increase medial prefrontal glutamate activity, or it could reduce functional connectivity in the subgenual anterior cingulate. So these are some studies that I was involved in, looking at these questions. Firstly, effects of ketamine on the resting bold response. So there was a study by Bill Deakin from 2010 which showed reductions in anterior cingulate activity following ketamine. We showed the same thing in 2015. We gave ketamine to 13 healthy volunteers and found reductions in subgenual anterior cingulate activity. This has then been looked at again by Bill Deakin's group, and they found that this effect wasn't maintained. What they think was that this was possibly due to the ketamine being given as a bolus infusion, because when they gave ketamine as a slow infusion, they didn't see this reduction in anterior cingulate activity. Instead, they saw increases in brain activity in other brain regions, and they found that higher levels of activity following ketamine in the more anterior cingulate area of the brain correlated with antidepressant effects at 7 days. So still a bit unclear, but this seems like it's more likely getting to the actual mechanism. So we've also shown that ketamine has effects on brain glutamate in the brain. This is a study from 2015 by Laura Rowland, which was 2005, which showed the first effects of ketamine in healthy volunteers on brain glutamate levels. I did a study in 2012 following up on that, again showing increase in glutamate levels following ketamine infusion. And then there's been some other studies, a more recent study looking at the same thing, levels of glutamate in the brain, again showing elevated glutamate and GABA following ketamine, but the response did not correlate with the antidepressant effects, so it might be that these changes in brain glutamate might actually be not key to the antidepressant effects of ketamine. And this study basically showed that ketamine did not cause any effects on brain glutamate and GABA, so still kind of wide open really as to what's going on. In terms of functional connectivity, this was a study from 2012 that showed that ketamine caused reductions in brain connectivity in healthy volunteers. A finding that we found this also in our study that published in 2016. But again, connectivity does not seem to be, reductions in connectivity don't seem to be found by all groups. This is a study in actual patients with depression, and ketamine in this study increased prefrontal connectivity. So again, very confusing. We're not really sure what's going on. And lastly, we thought that mTOR could be a very good target for blocking ketamine. This is a study, though, from 2020, where rather than giving rapamycin to rodents, rapamycin was given to people with depression when they were getting ketamine. And they, rather than blocking the effect of ketamine, rapamycin enhanced and prolonged the antidepressant effects of ketamine. So this is really unexpected, but adds to the mystery around what's actually going on with ketamine. So I wanted to say that these mechanisms are very contradictory. The antidepressant effects related to increases in bulb and metabolism in prefrontal cortex, which I showed in that previous slide. Ketamine effects on brain glutamate are unclear, but one group found correlations between reductions in brain glutamate and antidepressant effects. Increases in functional connectivity may be important in the antidepressant effect, and rapamycin may prolong the antidepressant effect, but the reason for this isn't clear. Could be due to its anti-inflammatory mechanisms. So on the very last part of this talk, I wanted to just cover about other potential mechanisms for ketamine. So does ketamine actually work on NMDA receptor blockade? This, I think, is a really seminal piece of work by Panos Zanos and colleagues and Carlos Zarati's group, looking at the metabolites of ketamine in rodents. In this study, they looked at mixture ketamine, racemic mixture of ketamine, and they compared it to MK801, which is a very strong NMDA receptor antagonist. They found that racemic ketamine and MK801 had a good antidepressant effect at 1 hour, but at 24 hours, only the racemic ketamine and not the MK801 rodents still showed an effect on the forced swim test. So this suggests that it's not just NMDA receptor blockade that's important. Then moving on, looking at metabolites of ketamine, there were 2 types of hydroxynorketamine that they were looking at. One was 2S6S hydroxynorketamine, and the other one was 2R6R hydroxynorketamine. And they found that only the 2R6R hydroxynorketamine had an antidepressant effect. And this was basically suggests that this might be the key molecule of importance in ketamine's action, and it might not be to do with NMDA receptors. This molecule seems to possibly activate AMPA receptors, but it's still a bit unclear as to how this might work. So this is important because we've come across this a few times, R versus S ketamine. So it's the R enantiomer, the R that leads to the R metabolites, and maybe this R ketamine might be more important for antidepressant effects. This is a very complicated slide that I'm not going to talk about, but if you're interested in it, you can read it here from Luke Jellen's recent review about R and S ketamine, which I wrote with him. And then lastly, I wanted to talk about opiate effects. There's a suggestion that some of ketamine's effects might be through the opiate system. If you block the opiate system with naltrexone, one group has reported that there was a reduction in the antidepressant effects of ketamine. And this slide, again from another review by by Luke Jellen, Dr. Jellen, looks at how the NMDA receptor and the mu opioid receptor mechanisms might converge. So in summary, ketamine seems to have robust antidepressant effects and may become more commonly used as a treatment for people with depression in hard-to-treat depression. I think this is going to lead to potential issues around capacity for provision and also cost. The use of intranasal ketamine might allow multiple patients to be dosed at the same time, potentially in a kind of day hospital type setting, similar to chemotherapy. But there's still a lot of uncertainty about the mechanisms underlying the antidepressant effects of ketamine, and it's possible that a drug targeting the same mechanism but with fewer problematic side effects may emerge. So lastly, I want to thank all the people who have been involved in the research, and thank you all for your attention.